Welcome to this educational program. This module provides an overview of prostate cancer and outlines some key factors in the process of making a decision about treatment for this condition. It is hoped you will already have reviewed the presentation entitled Understanding Prostate Cancer, which provides further background information about the condition. There are also other modules available that discuss the various prostate cancer treatments in greater detail. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider and may not address all the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. Each year, thousands of men are diagnosed with prostate cancer. Obviously, this can be difficult to accept, but once beyond the initial impact of the diagnosis, one must begin to make important decisions about treatment. Prostate cancer, more than many other types of cancer, can be difficult to deal with. There are different types of prostate cancer, ranging from those that grow very slowly to those that are more aggressive and grow faster. There also exist many different treatment options for prostate cancer. For these reasons, the decisions surrounding treatment can be confusing to many men. In order to make informed decisions, a man must arm himself with knowledge about prostate cancer and understand the specifics of his situation. Prostate cancer is a complex issue to discuss and to learn about, as there are difficult terms to understand, many controversies, and strong biases among healthcare professionals on how to treat it, and many highly emotional issues that affect decision-making. Many aspects of the treatment of prostate cancer are not black and white, and each individual situation is unique. Therefore, it is critical that a patient become educated and play an active role in choosing his treatment. The objectives of this presentation are to provide knowledge that can be used when making your treatment decision, to introduce topics to explore in more detail later, and to provide a framework and some guidance in helping you through the decision-making process. At this point, you will have spoken to your doctor and heard that your biopsies have confirmed prostate cancer. Since prostate cancer is usually slow-growing, many men do have the luxury of time to educate themselves about the disease and their situation. In most cases, you do not need to rush into making treatment decisions. Once the initial shock begins to wear off, start taking the time to learn about your condition and begin talking to friends and family about your diagnosis. They can provide emotional support to you as well as help you in your learning. Where possible, speak also to other men who have been treated for prostate cancer. As a precaution, however, remember that every man's situation is unique, and be careful not to compare yourself to others, or to believe that you will necessarily have the same outcome as another man. Finally, be confident in your decision once it is made, and try not to look back and second-guess yourself as you move through the process of treatment and recovery. Prostate cancer occurs when abnormal prostate cells, fueled mainly by the male sex hormone testosterone, grow uncontrollably to form tumors. Most of the time, this occurs without any symptoms. Rarely, a prostate tumor can interfere with normal bladder and sexual function, and if malignant or cancerous, can invade nearby tissues and organs and enter the bloodstream or lymphatic system, spreading to form new tumors throughout the body. Prostate cancer does not behave the same in all men. Some prostate tumors can be small, slow-growing, and present limited risk to a patient, while others can advance rapidly and threaten a patient's life. Though all prostate cancer is potentially life-threatening, early-stage disease can be cured. Your doctor will help to inform you about the type of growth rate and aggressiveness of your particular cancer. There are a couple key questions that must be answered as one begins deciding upon treatment. Firstly, is this a cancer that needs to be treated? Putting it another way, is it likely to threaten my life? This is a difficult concept to grasp, as many people would say that if a cancer is present, it should be treated aggressively. However, some prostate cancers are so small and grow so slowly that watching them may be all that is necessary. In some cases, delayed treatment after a period of observing the cancer can also be appropriate. The second important question is, what is the best treatment for me? In order to determine if this is a significant cancer that needs to be treated, one needs to look at his life expectancy and the details of how aggressive the cancer is. In choosing the best treatment, one needs to answer these questions. What treatments are available? What treatments am I a candidate for? What treatments provide the best results in my situation? What are the side effects? And what are my personal preferences? Determining the significance of a man's prostate cancer involves an assessment of the balance between how long he might live and the aggressiveness or risk of his cancer. Predicting how long a man might live is a complex issue and relies on a combination of his age, his general health, and a history of how long his family members have lived. Cancer risk can be determined by evaluating a man's PSA, the stage of his cancer, and the grade of his tumor, which is determined by the biopsy and the pathologist's interpretation. All of these variables will be discussed in detail shortly. Making this assessment is not a simple matter, and there is obviously a complex interplay between a number of different variables. The key issue in prostate cancer treatment decision-making is an area of intense interest among researchers in this field. Most physicians work within the guidelines illustrated here when helping their patients work toward a treatment decision. In general, treatment for prostate cancer is recommended when it is expected that a patient will live for at least another 10 years, or if he has moderate to high-risk prostate cancer. These concepts will be discussed shortly. Conversely, for older patients or those with significant illness that already threatens to shorten their life expectancy, who have low or sometimes moderate risk prostate cancer, aggressive treatment may not be the best approach. These patients are managed by so-called watchful waiting or active surveillance with delayed treatment. This will be discussed shortly. The group of patients who pose the greatest challenge in making this initial and critical treatment decision are those who have more than 10 years life expectancy and have low-risk disease. These patients fall into a gray area. Unfortunately, at this time, we are not yet able to determine who in this group will develop more aggressive disease and who would benefit from early aggressive treatment versus those who may have more slow-growing cancer that may never threaten their life. Men who fall into this gray area need to understand these two key observations. Firstly, aggressive treatment of all of these men would mean overtreatment of some, as 10 to 20% may have non-significant cancer that would not threaten their life. Secondly, a watchful waiting approach for all these men would mean missing a chance to cure some of them, as 20 to 30% have more aggressive disease than their biopsy suggests. Presently, most centers lean toward aggressive treatment in this situation, especially for men younger than 65, understanding that some men may be overtreated. Having said this, there are many regional differences of opinion. Work with your doctor to make this important decision. Much of the prostate cancer treatment decision has to do with the determination of what is referred to as the risk of the cancer. Risk is an estimate of the chances that cancer has already spread beyond the prostate, making cure of the cancer more challenging. Low-risk cancer means that it is more likely that cancer is still contained within the prostate. In medium-risk cancer, there is a medium chance, meaning 20 to 50%, that cancer has already begun to escape the prostate. In high-risk cancer, it is more likely, meaning more than 50% chance, that cancer has already spread beyond the prostate. Risk is determined mostly by a combination of three important factors: PSA, stage, and grade. To review, PSA is a protein made by the prostate and released into semen fluid and the bloodstream. The PSA in seminal fluid acts to liquefy the semen after climax, freeing the sperm to travel towards the female egg. The test used to detect PSA in the blood is very accurate, and PSA therefore provides an excellent marker to measure the activity of the prostate gland. Along with its use in screening for prostate cancer, it also has an important role in monitoring men with prostate cancer and following the effects of treatment. PSA is discussed in greater detail in its own separate module. Stage refers to the extent of prostate cancer growth as a whole. There are three components to determining stage, which relate to how the cancer behaves. They are the local extent of tumor, called the T stage, any spread to lymph nodes, called the N stage, and any spread or metastasis to other body organs, called the M stage. Each component, T, N, and M, is defined to determine the overall stage of the cancer. The T stage, or local tumor stage, is determined mostly by digital rectal exam, or DRE. There are 4 categories as follows. In Category 1, the tumor cannot be felt on DRE and was detected by screening, PSA, or by chance during prostate resection, called a TURP, or transurethral resection of the prostate. In Category 2, 1 or more lumps, or nodules, can be felt on DRE, but these nodules are contained within the prostate. In Category 3, the tumor can be felt to be growing into or beyond the outer limits, or capsule, of the prostate. In Category 4, the tumor has grown right through the capsule of the prostate into the wall of the pelvis or nearby organs. This slide shows graphically the details of the staging system that defines the local extent of tumor, or T-stage. You may pause here to review this closely if you like. This slide illustrates some examples of these various T-stages, with the tumor shown in red. You can appreciate that the extent of tumor increases in the higher stages. Intuitively, the chance of successful cure is highest with the lower stage tumors. Grading is the final important determinant of prostate cancer risk. When cancer is present in a prostate biopsy specimen, the pathologist will grade the prostate cancer cells according to how much they differ in appearance from normal cells. The grade indicates a tumor's aggressiveness, in other words, how fast it is likely to grow and spread. High-grade tumors are the most aggressive and the most likely to progress beyond the prostate. The most widely used grading system for prostate cancer was developed by a doctor named Donald Gleason, and the grade is therefore called the Gleason Grade or Gleason Score. The Gleason grading system involves inspection of the arrangement of cells in the prostate glands under the lowest power magnification with the microscope, and comparing this to the arrangement of normal gland cells. Higher grades indicate that the cells are growing more aggressively into more abnormal-looking patterns. Grades 1 and 2 are close to normal, and are rarely even reported these days. Grade 3 is clearly abnormal, but considered the least aggressive form of prostate cancer. Grade 4 is more aggressive-looking, and Grade 5 is the most aggressive. When the pathologist inspects the biopsy samples, he or she will not only assign just one grade, but will actually take note of the 2 most common grades seen in the entire specimen. These 2 Gleason grades are added together to give what is called the Gleason Score out of a total of 10. Because the possible grades go from 1 to 5, the possible scores go from 2 to 10. As mentioned on the previous slide, however, grades 1 and 2 are no longer reported by most pathologists, so the score now goes from 6 to 10, with 6 being the least aggressive form, 7 being intermediate, and 8 to 10 being the most aggressive form of prostate cancer. To further help you understand your biopsy report, note the following. Firstly, both grades and the score are reported. For example, 3 plus 4 equals 7 over 10, or 5 plus 4 equals 9 over 10. The first number reported, called the primary grade, is the most common pattern seen on the biopsy, while the second number, called the secondary grade, is the less common pattern seen. Therefore, a Gleason score of 4 plus 3 equals 7 is actually considered more aggressive than 3 plus 4 equals 7, because the more common pattern on the biopsy is the higher grade pattern. Note also that sometimes a third number, called the tertiary grade, is also reported. For example, if there is a tiny amount of high-grade cancer present in an otherwise lower-grade specimen. Putting it all together, your doctor can use the clinical stage, Gleason score, and PSA level to rank your cancer as low, medium, or high-risk cancer. This slide shows how doctors can determine quickly what general risk category a patient's prostate cancer falls into. Note that the highest scoring variable determines a man's risk. For example, if a man has a PSA of less than 10, clinical stage T1 cancer, but a Gleason score of 7, he is still considered in the medium risk category, even though the other 2 variables fall in the low risk range. Going even further, clinicians and statisticians have developed several mathematical tools that can accurately predict the percentage chance that cancer has escaped the prostate and might persist or reoccur after treatment to the prostate. The most widely used of these tools are a set of tables called the Partin tables, named after Dr. Alan W. Partin, who developed them with Dr. Patrick C. Walsh and colleagues at Johns Hopkins University. Based on an analysis of more than 4,000 prostatectomies done at Johns Hopkins, these tables use preoperative PSA, Gleason Score, and clinical stage to predict the final pathological stage after surgery. In other words, they give a man an idea of what the likelihood is that his cancer is really confined to the prostate at the time of diagnosis. By entering PSA, Gleason Score, and stage into a calculator programmed with these tables, a man can be told his statistical odds of the following outcomes: organ-confined disease, meaning all the cancer is limited to within the prostate; extraprostatic extension, meaning that cancer has directly extended through the outer capsule of the prostate; seminal vesicle invasion; and lymph node invasion. These variables of the pathology report are chosen because they have been found to be the most important in determining a man's outcome after surgery. The first important point to make about the Partin tables is that the numbers provided are statistics only, and they do not say anything conclusive about what will transpire in your individual situation. For any one man, the chances of a particular outcome are either 0 or 100%, i.e., you are either cured or not cured. Statistics simply allow one to get a better feel for the degree of risk in his particular case, but they only apply to a population of people with cancer and not an individual person with cancer. Sometimes, calculating these numbers and having even more information to deal with can leave a man feeling even more uncertain about his situation. A second important point is that the numbers provided by the Partin tables give a man an idea of what the final pathology report might look like following radical prostatectomy. However, they do not definitively tell one whether his surgery has been curative. Even with seemingly organ-confined disease on a pathology report, it is possible that a few cancer cells have spread beyond the prostate at the time of treatment, and development of more cancer after surgery is still possible. On the flip side to this, sometimes a pathology report will show that disease has spread into the capsule of the prostate, but the cancer never reoccurs afterwards. This is why these numbers have to be taken with a grain of salt, and why it is so important to maintain close follow-up for many years after prostate cancer treatment. A final important point about the Partin tables and the preceding discussion is that they do not take into account certain other variables that may also be important in determining a man's degree of risk, such as the number of biopsy cores containing cancer, in other words, the volume of cancer on the biopsy, the percentage amount of high-grade cancer on the biopsy, and possibly certain other tools that are under investigation, including DNA analysis, microvessel density, tumor proliferative markers, MRI imaging, and prostate scanning. There are usually a number of treatment options available for managing prostate cancer. The treatments recommended by a doctor will depend mainly on the stage and grade of cancer and a patient's general health and age, and this topic is addressed in detail in a separate module. Regardless, for early-stage prostate cancer, the aim of treatment is cure, while for later-stage cancer, the aim of treatment is to extend life and help relieve symptoms. This slide summarizes the many current and emerging therapies for prostate cancer, according to the clinical situation. In some men, it may be best to simply monitor the situation and not intervene with therapy if it is felt that the cancer will not impact on life expectancy. This is called active surveillance. In many men, however, treatment is aimed at curing the disease. Such treatments can be grouped according to whether they have a proven track record and well-defined long-term outcomes or not. These are listed here and are discussed in more detail in separate modules. Finally, some men present with incurable disease or experience a reoccurrence of cancer after other treatments. In these men, along with possible local treatment to the prostate by one of the above methods, so-called systemic therapy with hormone treatment or chemotherapy may be required to control the disease as long as possible. In some men with slow-growing prostate tumors that are found at an early stage, it may not be necessary to undertake active treatment. Instead, active surveillance may be undertaken, which involves closely monitoring a patient's condition without giving any treatment until symptoms appear or change. A patient's progress is monitored through regular PSA tests, a periodic digital rectal exam, and possible continued biopsies. The frequency of these tests will depend on the level and progression of the cancer and the exams will indicate if and when active treatment should begin. For some men, watchful waiting or active surveillance may be difficult, and they would be emotionally distressed by knowing that cancer is present but not actively treating it, or if they experience a great deal of anxiety as each follow-up visit approaches. Your doctor will try to alleviate this anxiety, but speak openly with your doctor if you have such concerns. Surgical removal of the prostate and surrounding structures to cure or control cancer is called a radical prostatectomy. This operation is most often done through a small incision or cut in the lower abdomen, but may also be done with an incision in the perineum, the space between the scrotum and anus. Radical prostatectomy may also be done laparoscopically, where small instruments are passed into the abdomen and the procedure is performed under video guidance. This technique is being used increasingly, and data on its effectiveness is accumulating. The laparoscopic technique may be done directly by the surgeon or with the assistance of robotic technology. This slide shows how, during radical prostatectomy, the prostate, part of the seminal vesicles, and the ejaculatory ducts are removed, and the opening to the bladder is then sewn back to the cut end of the urine channel or urethra. Radical prostatectomy is potentially curative therapy, especially in low and moderate risk disease. In high risk disease, it may still cure some patients, though the likelihood is lower. Having said that, even in high risk disease, there may be a survival benefit for some patients, though this subject is controversial. A recent article in the New England Journal of Medicine has shown that the predominant curative benefit to patients with prostate cancer, in fact, may be to those with high-risk features. Patients considered for this operation must be generally well enough to undergo a major operation and should generally have a life expectancy of at least 10 years. Note that, while radical prostatectomy is widely available and a very commonly performed surgery, the laparoscopic and robotic techniques are not necessarily available at all centers. Some of the pros of radical prostatectomy are listed here. As noted, it is commonly performed and widely available, and it has well-defined long-term cure rates. The surgical technique has been refined over the years, and it is a safe operation as a rule, with most men requiring only a short hospital stay. Another advantage to surgery is that the urologist can often spare the nerves running alongside the prostate to preserve bladder control and erections. One potential disadvantage of surgery is the need for a catheter for a few days to a few weeks afterwards, although this may be less time than required for some other therapies. Possible long-term side effects include persistent urine leakage, or incontinence, in about 8% of patients, and erectile dysfunction in somewhere between 20 and 80%, depending on your situation and the expertise of your surgeon. All of this is discussed in great detail in separate modules on this subject. Radiation therapy is another type of prostate cancer treatment, which uses high-energy X-rays or other types of radiation to kill cancer cells. There are two forms of radiation treatment: external beam radiation and brachytherapy. External beam radiation uses a machine outside the body to send radiation towards the cancer. Typically, patients might receive treatment once a day, 5 days a week, for a 6 to 8 week period. Hormone therapy is often required before and after radiation therapy, depending on the risk category of your cancer. This type of treatment can be used not only to cure or control cancer primarily, but also to treat a reoccurrence of cancer after surgery, and for the treatment of spread of cancer called metastases, especially to the bones. Brachytherapy uses radioactive seeds or pellets that are placed directly into the prostate. The seeds are left there permanently, and the radiation is given off gradually over a period of months. This treatment is usually restricted to smaller prostates and lower-risk disease. And again, hormone therapy is sometimes required before and/or after treatment, especially when used to shrink very large prostates to a size that is easier treated with less seeds and overall radiation. Possible benefits to radiation therapy include the fact that it is perhaps less invasive than surgery, which means that there will potentially be an easier recovery, and that it can be done on less healthy or older patients. External radiation does not require an anesthetic or hospitalization and is truly an outpatient procedure. Radiation therapy is also widely available, and also has well-defined long-term results. Finally, newly developed techniques in this field allow doctors to better focus the field of radiation on the prostate. Conversely, in some men with higher risk disease, it may be an advantage to be able to adjust the field of radiation to a wider area. Possible disadvantages of radiation therapy include the fact that not all patients are candidates for brachytherapy. In other words, only those with low-grade disease, smaller prostates, and who are able to have a general or spinal anesthetic, and that hormone therapy is often required for both techniques. Hormone therapy has its own set of possible side effects. The most important side effects of radiation are the effects that it can have on nearby structures, such as the bladder or rectum. In the short term, one may experience diarrhea, blood in the stool or urine, trouble urinating, or the need for a catheter for a few days to many weeks. The long-term effects of radiation may include urinary symptoms, especially frequent or burning urination or blood in the urine, narrowing of the anus or rectum, and erectile dysfunction. With respect to the latter, erections are generally better preserved following radiation versus surgery in the short term, but may decline over time as the long-term effects of radiation set into the tissues of the penis. In cryoablation, the prostate is frozen, killing the cancer cells. This can be done as a primary procedure for localized prostate cancer or after failed radiation. It is done only at select centers, so is not available to all men. Erectile dysfunction is to be expected after this treatment, so this should not be an issue for any man considering it. As with brachytherapy, a catheter in the bladder may be required for some time after the procedure, and urinary symptoms may persist in some. High-intensity focused ultrasound, or HIFU, uses high-energy sound waves to destroy cancer cells. This is an emerging treatment which is gaining popularity because of the exciting technology and the fact that it is a relatively minor procedure. However, please understand that there is no adequate long-term data available as yet on this therapy. HIFU is available at select centers only. As with brachytherapy and cryoablation, some patients may experience urinary symptoms and prolonged difficulty voiding. The growth of prostate cancer is driven by the male hormone testosterone, so removing testosterone can temporarily cure the cancer. This type of treatment is called hormone therapy. Unfortunately, hormone therapy cannot provide long-term cure, as eventually, after about 1 to 2 years, the cells may undergo change and start to grow again without the need for testosterone. At that point, the cancer becomes more difficult to treat. There are several uses for hormone therapy. It can be given before other therapies to try to maximize their effects, in which case it is called neoadjuvant therapy. It can also be given after other therapies, and is then called adjuvant therapy. Furthermore, it can be used to treat a reoccurrence of prostate cancer after other treatments, and to treat cancer that has spread or metastasized. Hormone therapy can be given continuously or in an intermittent fashion. It may be given as pills, injections, or through surgical removal of the testicles, where 95% of the testosterone is produced. Some common side effects of hormone therapy include hot flashes, breast swelling or tenderness, and fatigue. Other types of prostate cancer treatment currently used or being tested in clinical trials include chemotherapy, a treatment that uses drugs to stop the growth of cancer cells, biologic therapy, a treatment that uses a patient's immune system to fight cancer, transperineal microwave ablation of the prostate, or TAP, a technique that applies microwave heat energy to the prostate to kill cancer cells, and gene therapy, the insertion of new genes into cells to alter a tumor or a patient such that the cancer can be eliminated more easily. The outcome or prognosis of prostate cancer depends on a patient's PSA level, his Gleason score, the stage of cancer, the number of positive or cancerous biopsy specimens, and his age, general health, and support system. Though the number of men diagnosed with prostate cancer remains high, survival rates are improving. It is estimated that 89% of men diagnosed with the disease will survive at least 5 years, while 63% will survive 10 years or longer. Even after successful prostate cancer treatment, it is important to have regular follow-up exams to check for disease recurrence. This usually involves a checkup every 3 to 12 months, which includes a PSA test and possibly a digital rectal exam, depending on the situation. In summary, the following are some things to consider when making a decision on how to treat prostate cancer. Do I need treatment? Am I aiming for cure or control of my cancer? What treatments am I a candidate for? What options are available to me? What is the long-term success rate of treatment? What are the risks and possible side effects of treatment? And how might treatment impact my quality of life? Listen to your doctor to understand your condition, and try to learn as much as you can about it. Discover what treatment options are available to you. Talk to family and friends about your diagnosis and to others who have been there, understanding the differences amongst different men's situations. Use local and other resources on prostate cancer, which are widely available. Finally, once the decision is made, commit to it and don't look back. As indicated in this presentation, for many men, treatment probably does not need to be rushed into, allowing time to learn and prepare oneself. Having said that, in other men the need for treatment may be more urgent, and your doctor can discuss this with you. Regardless, it is safe to say that once you have made your decision and emotionally committed to it, treatment should proceed as directly as possible to optimize its effectiveness and to alleviate the anxiety of waiting for it. These are just a few of many online resources available to educate you on prostate cancer and help you find support. There are also many books written specifically for patients with prostate cancer, and this is just a sample of several. These may be available at your local medical library, bookstore, or prostate center. These medical references were also used to assist in preparing this presentation and are available for you to review online or at your local medical library. It is our sincere hope that this module has furthered your understanding on making a treatment decision for prostate cancer. We wish you the best for the future and thank you once again for viewing this educational program.